Good afternoon and welcome everyone to today's session for CaraConference 2020, HIV Now and Next. Keracle is Cincinnati's comprehensive AIDS service organization with a mission to positively change lives in the fight against HIV/AIDS. You can visit us on our website at caracole.org or find us on Facebook, Instagram, and Twitter with the handle at @WeAreCaracole. And if you're feeling social today, please use the hashtag CaraConf. If you're joining from a laptop or a desktop, your screen should look like this. And if you have technical questions, please use the chat function. We have someone monitoring that. If you have content-related questions, please use the Q&A function, and we have someone monitoring that for questions as well. If you've joined via a mobile device, you can get to the chat function through the More button at the bottom right of your screen, and you can find the Q&A section at the top right of your screen. We want to thank our sponsors and presenting partner, Maytech, Midwest AIDS Training and Education Center through the University of Cincinnati. Sponsors include Gilead and Theratechnologies, and support comes from Grace Hospice. And today we're going to hear a quick message from our sponsor, Theratechnologies. Theratechnologies is a commercial stage biopharmaceutical company. We currently market prescription products in the United States, Europe, and Canada. Our commercialized products and our research pipeline focus on specialized therapies addressing unmet medical needs in HIV and oncology. Thank you to Theratech for their support of CaraConference 2020. And at the end of today's sessions, we'll have a survey that will pop up. Please complete that survey. We value any and all feedback. And if you're looking for CEUs or continuing education credits, you've got to fill out that survey. Thank you. And right now, I'm going to turn things over to Mitch Hines, our Director of Client Service, our Director of Client Services here at Keracle.
Thank you, Adam. Thank you. Welcome, everyone, to Keracole's third CaraConference. As Adam said, I'm Mitch Hines, Director of Client Services here at Keracle. And I suppose if there's anything positive that's come out of the pandemic, it is being able to use creative things like virtual trainings such as this one. So I've tried to imagine what our social services world would look like had this occurred 10 or maybe even 5 years ago. So we really appreciate you making whatever adjustments you've made to be able to participate with us. Today, I think you're in for a real informational treat. We have with us 3 panelists, all of whom are Caracole key staff who represent initiatives in each of our major programs, which, as you all probably know, is prevention, housing, and care. First is representing our prevention services is Rob Gaylor. Rob is a licensed social worker, and he provides harm reduction services across both county and state lines to persons who use and or inject drugs. The range of harm reduction activities that Rob provides includes those at a Syringe services program, which is located on site at Caracole. Representing Caracole's housing program is Matt Parker. Matt is our site-based permanent housing program manager, and he has much to share about working with and serving people who are HIV positive and are high needs clients within a Housing First low barrier program model. And then lastly, we have representing Caracole's case management services, Jenna Leisure. She also is an LSW, and Jenna is one of a team of 2 medical care coordinators who provide assertive community-based case management services to HIV positive persons who are not yet engaged in medical care. Her project, which is known as viral load suppression for HIV, is recognized as an innovative approach to working with young African American men who have sex with men. So Adam, I believe you are up.
Thank you, Midge. I will be monitoring today's conversation with the 3 panelists who will be on screen in just a moment. I have a few questions to get us started, and then once we get through the initial questions, we'll be taking questions from the audience. Please put those in the Q&A function. And so just waiting for the panelists to show up. There we go. Okay, so we've got Jenna and Rob and Matt. Thank you, all three of you, for joining us today for this discussion. I'm going to start off with a question for Jenna. So, as Midge mentioned, you were in the viral load suppression program, which is part of our case management department, but it's a little bit different. You employ motivational interviewing to a pretty large extent. How does that differ from general case management?
Yeah, so motivational interviewing, for those of you who don't know, is a counseling approach that is very client-centered, and it elicits behavior change and also reduces barriers. So the clients that myself and my coworker Marcel work with are high needs and require intensive support, and also have a lot of barriers going on. Most of those include like mental health, substance use, and homelessness. So we utilize motivational interviewing mostly to elicit that behavior change, to want to get involved in their medical care, staying in their medical care, and then also reaching viral load suppression. So there are several stages in the motivational interviewing model, which are pre-contemplation, contemplation, preparation, action, and maintenance. I would say most of our clients start around the contemplation preparation stage, and then we really work with them to move towards the action. So how we differ from regular case management is we have smaller caseloads, so we're able to provide that intensive support. And then we also are allowed to we get 60 days really to try and engage someone in care. And they would move from contemplation or prep to action once they're engaged and they've attended their first medical appointment. From there, we try to address other barriers, which, might be getting them into the housing program, connecting them with an HRSC to address their substance use. And then they move through the stages once they've attended 2 medical appointments and they're on their medication and they're virally suppressed. We consider that maintenance in their medical care area. They might not be maintaining, sobriety, or they may still be homeless. So we do work with them still on reducing those barriers, but generally we try to get them very stable, and then we'll either graduate them from services completely, or we transfer them back to regular case management. So really we utilize the MI approach just because they have so many barriers and we're trying to address all of those. So it's definitely more hands-on and more intense.
Jenna, you mentioned how your caseload basically has a higher barriers. Can you talk about what some of those barriers are?
A lot of my clients on my caseload are either homeless or have a substance use problem. So when I'm working with someone that is dealing with substance use, it's hard to get them to focus on their medical care because it's just not a priority in their mind. It's hard for them to kind of, want to engage or remember that, okay, I have a doctor's appointment today. I need to call Jenna, or Jenna's going to be calling me, to come pick me up and take me to that medical appointment, because their mindset is just, how am I, going to get well today, or where am I going to sleep tonight? So it's just really hard for them to focus on, taking medication every day, something that's easy, for someone that's not battling all of those barriers. It's just not something that they wake up and think about every day. So it's hard to keep them engaged in that area. So a lot of times we start, hey, we do want you in your medical care, but what's your priority? What can we do to help you? So that you are going to be successful once we see the doctor and you're going to stay in your medical care. So it's not always hey, I'm meeting with this client and we're going to the doctor the next week. Sometimes it's 3 months later. I still have clients on my caseload right now that haven't seen the doctor and haven't started their meds, or they've started them and they just stopped taking them. So I would just definitely say, like, keeping them engaged in services in general when they're dealing with those barriers.
And not to continue to put you on the spot, Jenna, but so you're talking about clients that you have on your caseload that aren't attending medical appointments, and kind of, it sounds like they're not following through. So with certain things. So does that not create an issue for you? And so you'll continue working with people even if they're not medically engaged? And if so, why?
Yeah, so we will continue working with someone as long as they're engaging with me in some way. It might not be about their medical care, but as long as, I can go see them once a month or talk to them on the phone a couple of times a month, we're going to keep them open in services, because that to us is showing that contemplation stage. Like they want a case manager and they want to change. They just don't know how to do it yet. And that's where we utilize that MI. So that's why we keep them open, just because they are showing some sort of motivation towards that change. It's just figuring out what's going to work for them to make that change. And sometimes it takes 6 months.
Okay, thank you.
You're welcome.
And the next question is going to be for Matt. So Matt, you've been the permanent supportive housing manager since Keracle House 3.0 opened. So could you talk about kind of how you've seen the idea of housing first and permanent supportive housing impact our residents?
Absolutely. So at Keracle House 3.0, and for everybody that isn't already aware, we refer to it as 3.0 because this is sort of our third physical iteration of Keracle House. We house 19 high needs individuals between two buildings. And we practice the housing first philosophy, which really is the idea that housing is prioritized above any other need that an individual might have, because housing is a basic fundamental human right. And without permanent, supportive, and stable housing, a lot of our residents, clients, et cetera, are unable to successfully begin to engage in any of the other goals that they might have, whether it be substance abuse treatment, HIV, viral load suppression, seeing their doctor, increasing their income. All of that is really, in a way, impossible or incredibly difficult to obtain without some kind of stable housing. So we really put the focus on housing as the first priority. And at Caracole, I think our philosophy even extends a little bit more in terms of the fact that we look at housing as healthcare. When we say that, we've seen through our programs and through Keracle House itself, but through all of our other housing programs, that as people become engaged and have a stable place to live, we see greater viral load suppression. And we see better outcomes overall for the individuals that live in our housing programs. The permanent supportive housing subsidy is really the idea of when somebody comes into our program, there isn't a defined amount of time that they can remain in that program. It really is meant to be sort of guided by their needs, and they're able to stay housed in our program until they become stable. And we have the opportunity to then create a plan that may move them on to a different subsidy. Generally, at Keracle House, we've had people that have come and gone. The program is rated about its 2.5-year mark. We have some clients that have moved in and have moved out and on to other programs, such as Cincinnati Metropolitan Housing Authority Housing Choice Voucher. And we have transitioned some people from Caracole House into our Shelter Plus Care program. The real difference at Keracle House is that it's site-based. We have staff at the building on site 24/7, along with a dedicated case manager that handles their medical needs. And it is essentially the highest level of service that Keracle has to offer. That is where, as I said, our highest needs clients go, so that we can serve them in the best way possible. So I really think hopefully that answers the first part of the question that Adam asked.
Thanks, Matt. And just a follow-up to that, since you've been there from the beginning and have really been a part of creating that program, can you talk about, and it was kind of new, at least for our area, to have that type of housing program available, especially dedicated to people living with HIV. Can you talk about what maybe was the biggest surprise that has come out of this kind of new endeavor?
Absolutely. Well, that is that's a great question. I don't know if I can pinpoint the biggest surprise, because let me assure you, there's been lots of surprises, and there continues to be lots of surprises every single day. I think everybody at Caracole that has an idea of our program understands that. One of the things I don't know if we could call it a surprise, but it has been a real learning curve, is the understanding of how, when working in a housing first environment, how we are able to work with clients to try and get them to adhere to what we more so refer to as the expectations of Caracole House. This year, we revamped what we referred to as the house rules. And it went from 6 pages of rules down to a 1-page concise document that really has 3 specific rules, and the rest are, as I said, what we call expectations. The rules are very, very simple. People have to pay their rent. They have to abide by our visitor policy, and we do not have any kind of tolerance for violence, threats of violence, or weapons. So when outlining those rules, with Housing First, the goal is to keep clients stably housed no matter what. So in a lot of situations, that doesn't give us a whole lot of leeway, I think, for what people would refer to as traditional consequences. In the normal, I think, everyday kind of world, people think, if you break a rule, you're punished for it. At Caracole House, that's not really how things work, because, ultimately our biggest, I guess, punishment that we would have, and we don't even want to refer to it as that, would be eviction. And that is absolutely the last thing that we want to do in any situation, because when you're working with Housing First, eviction is the exact opposite of that. So the biggest surprise has been trying to learn how to work with the clients and build those interpersonal relationships with them, so that we are able to gain a level of respect with the clients. And that has been really critical, because when you gain that respect and you gain that trust, then that is whenever the residents and clients really want to work with you to follow the rules and expectations, because, as I said, they have that respect and they don't want to disappoint you. So maintaining those relationships, having those difficult conversations, that has been probably one of the biggest learning curves and biggest surprises, I would say, as opposed to, working with clients maybe in some other housing programs that aren't quite as flexible as what we offer at Caracole House.
Thanks for that, Matt. And now I'm going to turn over a question to Rob, and then we'll get to the questions from the audience, okay? So Rob, from what Jenna was talking about with motivational interviewing, she made me think that it sounds an awful lot like harm reduction, and you're meeting people where they are. Could you talk about how in your role in prevention, you utilize motivational interviewing and how that might look different, because you don't necessarily carry a caseload in the same way that Jenna does?
Sure. Yeah, those are both really good questions. So basically, where do motivational interviewing and harm reduction overlap, and how what does our interaction with clients look like as compared to a more traditional case management kind of thing? So I'll try to answer both those. So obviously there's a lot of overlap, as you said, for motivational interviewing and harm reduction. Mostly, it refers to, I would say that the harm reduction model really does quite a bit lean on a good understanding of those stages of change. Except maybe one difference is that motivational interviewing, according to my understanding of it, is sometimes really trying to push somebody in a certain direction, but doing it in a way that is meeting them where they're at, and it's in a lot of ways self-directed. I think harm reduction maybe scales back that portion just a little bit, and really is, meeting somebody where they're at, but not leaving them there. That's that's a corny phrase that a lot of people will use, but it is true. So, I think we as a team draw from the learning we've done with motivational interviewing a lot because of our brief interactions with people. I mean, motivational interviewing in a lot of cases is meant for those brief, 10, 15-minute interactions, and making sure that we're very directed about our language. And, and this is kind of leading into that second question here. The way that we work with clients is completely different than the way that more traditional case management and even the more innovative case management like the VLS program looks like. I mean, it looks completely different. A lot of times, we are seeing people maybe once every 6 months or less for 5-10 minutes, and we have to really make that time count. So for some people, that's very different. For some people, it's just, you're engaging folks by just being a familiar face. Maybe they just see you at a community location once a month, and eventually they come up and chat with you. Maybe your interaction is as extensive as, oh yeah, sure, you want some condoms? Here's a bag. Like, take as many as you'd like, and then that's your conversation. All the way to if there's somebody who's really like, it comes, and this happens more than you might think. People that come to us and say, hey, I'm tired of this. Like, maybe they just got a bag of 70 syringes, but they're like, I want to be done with this. And then, okay, let's have that conversation. So it really depends. But it's just such a different animal. Outreach and things like that are just such different animals compared to carrying a caseload.
Thanks, Rob. So we will get to audience questions in just a moment. I'm going to do a poll for the audience right now. Part of this discussion that we'll get more into later is the collaboration between our departments and the different programs in the department. So some of the polls are kind of getting at that question. So I'm going to launch the poll right now. And if you, there you go. And I'm going to leave it open for about a minute. And if you can answer questions in there, please do. And while we're waiting on that, I'm going to get to some of the questions that we have from the audience. Let's go with this first one, which would be for Matt. The question is there an expectation of sobriety in the permanent supportive housing building, or does it work in a harm reduction model?
Excellent question. It works very much in a harm reduction model. We do not have an expectation of sobriety. And that also goes along with Housing First. Housing First does not have an expectation of sobriety. So working with the harm reduction model, for anybody that isn't familiar already, harm reduction is a set of tenets that really work to guide interactions and working with people that abuse substances. And probably the most main tenet, and I'll read it verbatim, is that harm reduction accepts, for better or worse, that licit and illicit drug use is part of our world, and harm reduction chooses to work to minimize its harmful effects rather than simply ignore or condemn them. So exactly, that's what we try and do on a daily basis, is work with clients in order to, we use the phrase quite often, meet them where they are, and then begin to step by step, as they move through pre-contemplation, contemplation, or even action, have them engage in behaviors that reduces the risk of whatever dangerous activity they're doing. So that can include linkage to syringe services exchange, checking in with staff before use, so that staff could check with a client afterwards to make sure that the client has not overdosed. We keep Narcan on hand for any overdose reversals, and it is readily provided to any resident that asks for it, regardless of whether or not they personally engage in substance abuse. We work with clients to do other things that may not directly be related to their substance abuse, such as enrolling clients in a direct rent program. And for anyone that is not familiar with direct rent, it is kind of like a much more relaxed payee service, where a client enrolls in the program, the direct rent provider receives their money every month, whether it be their SSDI, SSI, et cetera, and then uses that money to pay their rent and immediately disperses the rest of the money to the client as they wish. And it can be all at once, it can be weekly, et cetera. But you can view that as a harm reduction tactic very much right there, because it ensures that a client is meeting the need of paying their rent so that they stay stably housed, as opposed to the client immediately getting all of the money and being put in a situation where their addiction might come first. So yes, we very much engage in all kinds of harm reduction practices, and we're constantly looking for new methods, new ideas, and things like that to engage our clients and help them along their journey, whether it be to recovery and complete sobriety, or just a reduction of the dangerous habits or uses that they may have.
Thanks, Matt. So it really sounds like at Keracle House, kind of like you said, the only reason that somebody would be exited out of that program would be violence. Is that right?
That's really what it has come down to is, yes, violence is one of the things that we really have no tolerance for, because in a small community like that, it can really throw things out of whack. And with 19 people, it's just not doable. At Caracole House, it is not communal living. It's not transitional style living. Every resident holds their own lease. They have their own individual apartment. So it's very much like them being out in the community. They just have that on-site support there. The other thing that could lead to eviction is if a client refuses to pay rent. But Caracole has been extremely flexible in that. And I think that is one of the other fundamental tenets of the program that makes us so successful, is by being site-based, Keracle is able to act as the landlord, and we really, in that capacity, are able to tolerate many other negative or unusual behaviors that would cause a client to become homeless again if they were in a scattered site or community setting with a private landlord. So we've had an instance, where a resident has gotten 4 months behind, and we do everything we can in order to engage them in a repayment plan so that we can avoid eviction.
Thank you, Matt. So let's go to some other questions. I thought a question like this might come up. I'm going to direct this to Rob first, and then we'll get the other panelists' feedback. Could you discuss how COVID-19 has impacted some of the efforts that we've been talking about?
Gladly. The short answer is quite a bit. And, a lot of what we do on the harm reduction services team is it's outreach focused, right? So it's not. Well, there's a couple things that are going on. So one is we are oftentimes, prior to COVID, Keracle has an HIV testing van. So we take that van out into the community, park it in certain places, or maybe we're testing at a particular partner organization's like on site. And, we've got a table out, we're engaging people, where people are coming onto the van to get tested. A lot of times what that looks like is congregating of a lot of people. And, when we're doing our best work, we are contacting people who are at high risk for HIV, which means there might be any number of underlying conditions that people are having to deal with on a day-to-day basis. And then you throw COVID into the mix, and we had to really think about how to provide our services in a way that is most responsible while still doing the work that we do. And I'm going to be 100% honest, we still don't have an answer to all of those questions. We don't know what that looks like. We certainly, have had to go back to the playbook quite a few times. Now, full disclosure, what COVID has caused us or impelled us to reconsider is that model of one-on-one engagement in the environment versus, more what we've been referring to as like distance-based outreach. And so that would be something like delivery of materials over the phone, engaging people through the internet. COVID in a lot of ways has encouraged us to start to think outside of the box. We cover quite a few counties in the tri-state region here. There's only 3 of us on the team, and we can't be everywhere at once. And so, we were doing pre-COVID, we were doing a really good job of getting in touch with people in Cincinnati and in northern Kentucky, but we still had several other counties that we weren't even coming close to touching. That maybe we could only touch, we could only engage with through some of these more distance-based methods that aren't tied to maybe a particular location or a particular time of day. So we've tried to, a couple things, really go back to the drawing board, and then 2, team up with partner organizations like Hamilton County Public Health and Northern Kentucky Health Department, or GCB and the PATH team, the homeless outreach team. Try to piggyback on some of the services that they're offering, and kind of go from there. So I could, of course, probably talk about this forever, but I'll stop right there. That's a really good question.
Thanks, Rob. It sounds like I think you're right. In prevention, we're still trying to figure things out. Jenna, we'd be interested to hear how it's changed for your VLS program. Oh, you're on mute.
Sorry about that. definitely seen a lot of changes, and it's been really hard. For the past 6 months, I already work with clients that are hard to engage. So taking away that face-to-face interaction just makes it harder for us to kind of build that rapport with our clients, and get them moving towards goals. A big piece of our job is transportation. And a lot of times that's where conversations happen, is in the car. People just feel more comfortable opening up in the car. So without that piece, not only are my clients not going to see their doctor because they don't want to deal with riding the bus, the anxiety of, am I going to make it on time? Am I going to miss the bus? Is it going to be raining this day? So a lot of times they'll just, they just don't go because they don't want to deal with those stressors, as well as just not being able to communicate with some of my clients either. And that's the only way I'm able to engage with them right now, is over the phone. So when my clients don't have a working phone number, and I'm used to, going out to the community, like I know where they've been staying or where their apartment is, just, popping in just to see how they're doing, make sure they're doing all right. And making them feel, like they're being supported. Just with that being taken away as well has been a big struggle. I think for me personally, just having to tell someone, I can't do that for you right now, but let's figure out a way that, we can make this work and still get it done for you, is hard for me because, we're social workers. We're supposed to be their helping hand. And it's hard. I also think that on the other hand of things, there has been some positives, just for my clients wanting to work, who are ready to work towards goals. They find it easier to talk to me over the phone, so they can be more honest about, I used yesterday, but, I don't want to use today. And face to face, they might not have told me that because I'm someone they want to please, and I'm someone that they want to, make proud, essentially. Sometimes they lie, or they're not lie, just kind of hide the truth a little bit, about, why they didn't go to the doctor, or, how many medication doses they've missed this week. So I think that on that end, it's been a positive change, just because I'm getting more information out of my clients that I am talking to on the phone. But on the other side of that, it's just only being able to call clients is hard when you can't call specific ones because they don't have a phone number to contact them at.
Thanks, Jenna. And what about at the houses? I imagine that, you were kind of deemed as essential through all of this. So how did that play out? Or how is that playing out?
Excellent question. I would have to say, I think out of the three of us, Keracle House was probably the least impacted by COVID. That's not to say that there wasn't still a great impact, but as you said, we were deemed essential. Keracle House did not close. Staff were still expected to report to work as needed if they were able. And it in some manner, things very much kept going on as usual. What I was greatly surprised about, and what I still have to commend the team at Keracle House daily, is that they really stayed focused and stayed dedicated to the mission of Keracle House, and people kept reporting to work. And it was just miraculous to see how they persevered through that. Our biggest changes really were coming up with creative ways and creative methods in order to be able to safely engage with the residents there. We were lucky enough to receive a very generous donation through Direct Relief, where we had a donation of N95 masks, sanitizing wipes, hand sanitizer and things like that. So we have maintained very strict and a very high level of standards of sanitation at Keracle House, making sure that doorknobs and railings and frequently touched surfaces are sanitized multiple times a day. And probably the biggest hurdle then after sanitization and making sure that things were clean was figuring out how to safely be able to engage with the residents that lived there, because the residents were so attuned to being able to come into the on-site office to chat with the staff in order to resolve their problems or disputes, or even really just, get an open ear to listen to them. And with COVID, that kind of close interaction in an enclosed space was just not possible anymore. So we worked to set up a socially distanced area outside of the office where we could meet with clients. We've worked to meet with them outside if possible. And if for some reason we do have to meet with a client in any kind of close proximity, we always make sure that, as I already said, things are sanitized. Both parties are wearing masks and using all proper precautions. The N95 masks have been very, very useful for the times whenever we actually have to enter into a residence unit to provide them with assistance, whether it be maintenance, food services, etc. Whenever the pandemic began, we were extremely lucky that we had a community organization that is near and dear to Caracole. It's a catering company. They provided 2 weeks worth of meals to every client that lives at Caracole House. And at the very beginning of the pandemic, that was nothing short of a miracle. We couldn't have been more grateful for that. As of now, probably the biggest hurdle that we still face, as Jenna already mentioned, is that the case manager and to a much lesser degree myself would provide clients with transportation to food banks and to doctor's appointments and things. And we have not been able to do that except in cases of emergencies when it comes to medical appointments. We've really kind of worked around that by providing the clients with bus passes as much as we can, making sure to provide them with guides on how to get around on the bus. And then to some degree, the on-site case manager, Anne, has done some picking up of food at pantries for clients. So we've made it work. Every single day I look and I wonder and I say, well, how did we do this? How do we continue to do this? And we just get through it day by day very much. And so far, I'm happy to report not a single resident has been diagnosed with COVID and not a single staff person has been diagnosed with COVID. Every time I say that, it's always knock on wood, but we're going to continue those high level of safety protocols in order to make sure that everybody remains healthy.
Thanks, Matt. I'm sure. I'm glad you plugged the staff. We have a great staff over at Keracle House, you and everybody else. And I am sure that there's a lot of, especially in the beginning, a lot of fear of being the person that brings things back to the house, because that's where they live. That's where our clients are living. Staff doesn't live there. So it's nice to hear the dedication of staff.
Precisely. It's been very much on our team. We try and educate the residents as much as we can, but, with some of them being in the middle of addictions or very much some of them being much more disconnected from the news than your average person. Some of them, I think, don't view COVID as seriously as an average person might. So it's been very much on the staff to keep things sanitized and, again, make sure that we're educating the clients about the proper procedures they need to take.
Cool. Thank you. And before we go to our next question, I think, Rob, you had something that you wanted to follow up on.
Sure. Yeah, I have to admit, Jenna and Matt have inspired me to look for the silver lining in my answer a bit. And so one thing I wanted to touch on was, a way that COVID has allowed us to improve the quality of our services, and that is specifically in regards to the Syringe service program that we staff on Thursdays. So it's this Syringe service program, or SSP, is ran by or overseen by the Hamilton County Health Department. And we just staffed this particular location. And pre-COVID, there was quite a lot of data that was being collected on each and every visitor that would come in. And so, you might have a line of people waiting to, get their materials. And maybe they're getting antsy because maybe they're getting sick, or maybe they are getting antsy because they don't quite trust the process. They think they're going to be arrested as soon as they walk out the door. Or maybe their ride is not going to wait around for them, but we would have, 5 to 7 minutes or whatever of questionnaires to go through with each person before giving them their materials. And COVID afforded an opportunity to really be more intentional about how we spend that time and pare down quite a bit of that data that's being collected. There's a lot of information that we're asking for where, at least on our end, there wasn't a clear reason as to why we were asking for that information. Like, how was this going to be used to benefit participants? And instead, where we used to spend 5 to 7 minutes with somebody and 4 to 6 of those minutes were spent on a survey, now we're getting information from people for 1 to 2 minutes, and we're spending the rest of that time actually engaging those people and building that relationship. Hey, even if it's as simple as, hey, how's your day? Good to see you again. Haven't seen you since, March or whatever. What's been new? What's different? Are you all staying healthy? And I think that's really important. And I hope that we can maintain that spirit as a community moving forward as, I guess the waves steady a bit. But that's all I wanted to add. Thanks for the opportunity.
Thanks, Rob. That's a really good point. I think that's something that all of our programs have kind of experienced, is a less data collection. And I think everybody involved in data collection very much appreciates that. So I am going to go ahead and share the poll results. So we asked, how many organizations are you partnering with to better serve your clients and provide active referrals? And it looks like most have 6 to 10. And the medical provider, 90% of people have those relationships. So that's good that there's, most people have relationships with the medical providers they're working with. So there's those poll results. I'm going to go into another question from the audience. Okay, so Matt, I'm going to start with you on this. This has a housing kind of bent to it. So how has the stigma of HIV been a barrier to clients being willing to accept housing in your program? It's a great question.
It really is a great question. And I have been surprised. Speaking specifically for Keracle House, I have been surprised because I thought that it would be a greater barrier than it is. Because, with the requirement to live at either one of the buildings, we have 2 that are side by side. Number one requirement for our programs is that a person must be HIV positive. So you can understand how, as I think the person that asked the question is probably alluding to, that stigma there, if it were to get out in the community about the requirements or what goes on at the houses, that could be a barrier. Most of the clients actually all of the clients that we have interviewed in our preliminary process to determine their placement there, that has not been an issue for them, surprisingly. And I think that really plays into that the clients that we house at Keracle House are so high needs that that is just not their fundamental concern. They have other things that very much overwhelm that thought, whether it be their substance abuse issues or just their general homelessness. Of course, we do have a couple of precautions in place. The first being that in Cincinnati, for many projects like this, typically there's a community process where you have to engage with the community in order to get approval. We, because of HIPAA, had to forego that process because by going into the community to a community neighborhood meeting and just saying, hey, we're Keracle, here's what we're going to do, that immediately discloses the HIV status of everybody that would live at those houses. Furthermore, we operate under a different name than Keracle. All of our housing programs generally function currently under the umbrella of Shelter Plus Care, which is not a separate nonprofit from Keracle. That is just the, pseudonym in a way that we use in order to maintain confidentiality amongst landlords as far as our clients go in terms of their HIV health. So those are some of the precautions that we have put in place in order to reduce that stigma and give clients some level of assurance that we're protecting their information to the best of our ability.
Thank you, Matt. And Jenna, I want to pose that question to you because I know you work really closely with housing for a lot of your clients. So I wonder, is their status a barrier to them accessing our housing programs from your client load or caseload?
I actually have not experienced that a whole lot. I would say the biggest deterrent for people is substance use. So a lot of them fear that I can't get housing because I'm not practicing sobriety yet. So it's just kind of talking to them about the housing first model and harm reduction. I will say I refer a lot of my clients to the tenant-based rental assistance program. And that's probably why I don't like the stigma of having HIV doesn't come up a whole lot with the population I serve. Substance use is definitely the biggest.
Okay. Cool. Thank you. And real quick, Matt, you had mentioned a moment ago or a little while ago about a rent holding program. Can you give a little bit more information on that program?
Sure. So we refer to it, at least here in Cincinnati, I don't know if this is a nationwide term, but we refer to it as direct rent. In the Cincinnati area, there are, at least through Caracole, there are two main providers that we utilize. The first is the Free Store Food Bank here in Cincinnati has a direct rent program along with payee services. And again, I want to reiterate that direct rent is a program which a client self-applies for. It is not something that's court-ordered like a payee service. It's a program that a client engages in of their own free will. So aside from the Free Store Food Bank, the other program in the Cincinnati area is called Support Management Solutions. It's run by a wonderful lady named Sharon Foster, and she is the one that engages in that. To speak a little bit more into the program, there are other options that clients can utilize in the direct rent program. The main focus is that they get their rent paid, but at least through Sharon Foster's program with Support Management Solutions, she can, I believe, pay up to 3 other bills for them, which could include their internet or cable services, their phone services, electric, etc. And again, that's all self-engaged by a client. Now, as for other services around the state, I really can't speak into that because I'm not familiar with what's offered in other areas. Unfortunately, I would probably say that direct rent services are readily available in the larger cities, Columbus, Cleveland, Toledo, Dayton, etc., and probably not so much in the more rural areas. But again, it is referred to as direct rent, and anybody that is on the session right now, if you're in a different area outside of Cincinnati, I very much encourage you to look into what direct rent services are offered in your area, because it is incredibly beneficial in stabilizing some clients that have a long history of non-payment of rent, because this just takes that whole process out of their hands, and that's one less thing that they have to worry about, and it gives them the opportunity to focus on other goals in their life. So yeah, I think it's a great program. It does have a fee, at least for Support Management Solutions. It's pretty reasonable. I believe it's about $17 a month. And to speak more into that, not only are they offering that service, but at least with Support Management Solutions, they offer a multitude of other things. They'll provide clients with household items as they become available. They will help with food, just all kinds of things. It's really wonderful, and I very much hope that other programs like it exist in other areas of Ohio.
Thanks, Matt. And to bring a question back to Rob, we talked a little bit about the different collaboration that we do in different departments. Can you talk about our new program or newish program of the Drug Users Empowerment Group, what that looked like before COVID and what that looks like now, and how we involve the entire organization in that? That's a long question, but you got it.
I'll try my best. So, we were really lucky to get some, I can't remember the exact funding path, but I know that it had come from the federal government, some money in 2019 to start a drug users empowerment group, drug users union, whatever you want to call it. There's a few around the world and some in the US that I would highly encourage folks to look up. But so we made some pre-COVID, we made some really good inroads into engaging people into that program. So, essentially we would meet, I believe it was monthly, and we would encourage people to come, we'd have dinner or whatever. And people who would participate we were able to, at that time, provide like gift certificates to make their time, gift cards. Yeah. To make their time, to acknowledge that their time is valuable and they're taking 2 hours out of their night to come and talk about really macro advocacy kind of stuff. So pre-COVID, we were making some pretty good strides. A lot of it was interesting, like the directions that the group was kind of going. But a lot of it had to do with becoming more educated about the rights that people who use drugs have, and also improving education to specifically the medical community. That was something that came up a lot. Now, when COVID happened, or when COVID really got going in February and March, and of course, we had to be safe about it. We had to stop these meetings, and serving food and all that kind of stuff was just a big no. And so we really haven't, the last month or so, we've tried to start it back up again and re-engage people. It's just much more difficult. We have I mean, I feel like a lot of people know this, but the chaos that COVID has kind of reigned really, I mean, it affects people on so many levels. And most of the people who are closest to the street, you know what I mean, who are with the fewest resources. So, let's say we had 4 people who were really interested in taking leadership roles of that in that group and pushing that group forward, and not having Keracle involved to like guide, if you want to say that. Well, some of those people, took the opportunity to get into, medication-assisted treatment. Some of those people lost income, and so their whole life has been flipped upside down, and what stability they had has been challenged by this. So we're working on ways to get that group going again, and it seems like the safest way to do that is to offer kind of a digital or virtual version of that. But I'm not going to lie, we've had struggles just finding a good time and being able to actually engage people and get people to, interested. Does that answer your question, Adam?
It does. Yes. Thank you. Yeah. Like so many things, COVID is throwing wrenches everywhere.
Right.
So we are like right at 1:00. We've got a few other questions, so we'll stick around and get those answered. If you do have any other questions that you want to ask, please put them in the Q&A function. If you do need to leave, please do so. Make sure that you complete the survey for us too, please. And hopefully you'll be able to join us tomorrow for our afternoon session, which is Correctional HIV Prevention and Innovative Programming. We'll have John Coco and Abby Abrams from Step Up Indiana, who are doing some pretty innovative work in correctional facilities with people living with HIV. So now back to the panel. So I'm going to start, let's put this to Jenna real quick. Can you give an example of maybe a specific client or a specific situation where you utilized prevention, case management, and housing all for this one client, and kind of what that looked like?
Yes. Actually, I have a specific client. He's no longer on my caseload. He was living at the house. I'm not sure if he's still there, but he was someone that was referred to me from the Hamilton County Justice Center. So I went down there and did his intake while he was still incarcerated. That way, when he got out, he had a support system in place already, and we could start working on housing. Unfortunately, when he did get released, he did not continue engaging. So he actually ended up being closed from services completely. A few months down the road, he actually connected with, I believe, Rob, down at, I forget the center's name, down on State or off of State. But Rob had connected with him down there, and he actually got re-engaged to services. And so that was pretty cool, kind of just like wrap around there of how we all kind of work together. And then from there, we actually referred him to the Keracle house that had just opened, and he was accepted and moved in there. So we do try to work collaboratively with each other. I know there have been a few instances that Rob also has reached out like, hey, I have your client here. They haven't been, I know you haven't been able to reach them. Do you need anything from them, or do you want to talk to them? Which is pretty cool. But I would definitely say that client moved through the program and was successful in the house for a little bit. I know he had some issues with drug use moving forward, and did not engage in his medical care for a little bit. And I actually don't know if the housing helped in that area or not, just because he was so unstable. And we did talk about, what is going to provide you with that stability. And it was always housing. So we were hopeful that once he did move in, he would be able to engage. And I believe if he's still open, he's working with Anne, who is the case manager at the house. And yeah, so I guess we do all work closely together, and try to like help each other out when we can. I do refer my clients to an HRSC if they are struggling significantly with substance use, not to push, recovery on them, but just so they can start practicing harm reduction.
Thanks, Jenna.
Mm-hmm.
Matt, what about you? The same question.
And you know what, Adam, would you repeat that question for me one more time?
Sure.
Make sure I stay on topic.
So just talking about, can you give an example of a client that you've worked with, maybe in your current role or maybe in your previous role when you used to be in prevention, about when you worked with maybe a specific person or a specific situation that touched all three of our programs and how that worked out for the client?
Yes, I'm trying to think of a specific person. And of course, the first person that comes to mind is the exact same individual Jenna was referring to, because I know all three of us on the panel work together on this person. I am, let me think. There's an individual in Keracle House right now that when this person was first referred, I know they had been engaged with Syringe exchange services through Caracole. So that would have touched on our harm reduction and prevention services. This individual came to Caracole House through the Cincinnati Continuum of Care, and they were matched up with us. They had been engaged with a street outreach coordinator. So whenever this person first came to us, they had said that they were HIV positive, but we did not have verification of that at the time. So one of the ways that we were able to touch base and work with prevention is to have them tested through our testing services as part of Caracole prevention, and then confirm their HIV status in order to maintain their housing. When it comes to case management and VLS, I know that they very much work hand in hand. And that is not so much me, but as part of Caracole House, more of the interaction that our on-site case manager, Anne, has with the other case managers, such as Jenna. Because Jenna has referred people that have come through VLS. And even when a client many times completes or graduates from the VLS program, they still have a lot of very, very high needs. And being able for the on-site case manager to continue to work with a VLS case manager or even a regular medical case manager so that they get the insight about the clients makes it so much easier for us to engage with them at Caracole House, because we're able to get that background and on some level an understanding of what drives an individual and what kind of traumas or other things that might have occurred in their past. So, it really is a whole loop, a whole circle at Keracle, where we all work together as very much a team to deliver services to the highest level that we can to all of our clients.
Thanks, Matt. And Rob, I want to pose that same question to you. And then after that, we've got one last question and I think we'll be done.
Yeah, sure. I mean, there's a few examples that I've got that where I was working with an individual that touched the different departments within Caracole. And my two teammates, Billy and Jamie, I would gladly toot their horns as well because they've got just as many of those examples. I guess what I will, unless you want some more specifics, one thing I'll say is, I guess just to more comment, if I may, on the dynamics that we share, and specifically these three departments, because, the prevention department at Keracle is, tripled in size in the early part of 2019, whereas, the housing department and the case management department medical case management department have been around for much, much longer. And so, working together to make sure that the way that I'm working with a particular individual is working in conjunction with whatever Matt and his team are working on, and whatever Jenna or Marcel as VLS workers are working on is really important. And part of that is, one benefit to our team, the harm reduction services team, is that we work odd hours and we do things that are much lower barrier. Right. So finding housing in Cincinnati can be very high barrier. But somebody getting sterile syringes from us can be pretty low barrier if they know where to find it. So that's what Jen is referring to when somebody shows up at, 7 p.m. Jen is not around because she works also weird hours, but might not be at the agency at that time. Right. But I can get a hold of her and say, hey, so-and-so is here. What can we do? What should we be working on to make this time valuable? But then the other part of that, so communication, but then the other part of that is too, and it's a challenge for us as people in the prevention department, is having a kind of being literate or fluent with the other programming that Caracole has to offer, because so many of us have not worked in, I'm lucky enough to have worked in medical case management before. But these programs change, and some of the other people in the prevention department have not had that same experience. And so we may have to constantly be learning how to work in conjunction in a positive way that is constructive with Jenna and Matt, for instance. So that didn't really answer your question at all, Adam, but I hope that was useful maybe to folks listening.
I think it was very useful. Thank you for dodging my question. So we've got two more questions, and then we're going to go. So this one is specific to Caracole House. So the question is, how long can a client stay at Caracole House? And then the second part of that question is, do you feel there are enough vacancies to meet housing demand, or do you hope for more units in the future?
Oh, great questions. I can pretty succinctly answer both of those. So there is not a predetermined amount of time that a person can stay at Caracole House. With it being permanent supportive housing, the idea is that a client can stay there as long as needed until they're stable and ready to move on. I know ideally with our continuum of care here in Cincinnati, we try and aim to make that 4 years or less. I mean, that's really kind of the out there and left field goal. Because that is one of the measures of success and outcomes of our program, is if we've managed to stabilize clients and keep them housed and then move them on to another subsidy. So yeah, we do have, like I said, that kind of out and left field goal, but there is no predetermined amount of time. I mean, theoretically, if a client was incredibly unstable and they needed to stay there for 10 years, I suppose that's possible. I hope that doesn't happen, because I think with the high level of service we provide at Caracole House, if somebody needs to stay there for 10 years, I think maybe that means we're missing the mark somehow. But it's always an option. Then as far as the question about housing goes, you know what, we absolutely, we could use more of this type of housing all over. Yes, I wish there were more units available. And the reason for that being is because, traditionally, Caracole House is site-based versus our other biggest housing program is shelter plus care, which is scattered site, which is where somebody receives a subsidy and then they have to go and be housed with a landlord out in the community. So that program, while our biggest and still very successful, is difficult because, if a client has lots of legal barriers, blocking their way from being housed with a private landlord, that's something we don't have to worry about at Keracle House because we're the landlord. And, if a client is presented to us, we say, yes, we can take you. And then if we have an opening, we can make that housing option happen as quickly as possible. So, that's really an ideal situation. The only, I guess, caveat that we have is our first building is funded by the Continuum of Care. So we have to take clients that already have a homeless certification. So they can come from one of our other housing programs, or they can be matched with us through the Continuum of Care. If we get a match, we must take that match and house them. The second house is funded through Housing Opportunities for people with AIDS. And that funding is a little more flexible. A person then only has to be precariously housed or homeless at that point. And in that program, we are very, very wide open. The only individuals that we're not able to take would be Tier 3 sex offenders. And that is because of the mailing requirement that happens if they were to move into the building. So, unfortunately, because we want to maintain confidentiality and kind of keep a low profile in the community, that mailing going out is just not something that we're able to deal with, unfortunately. But in short, yes, we could use much more of this housing. It would. I'm already exhausted, so hopefully we can get somebody else on board to help with that. But it is very, very much needed, and hopefully somewhere down the road it'll be an option that's available in the Cincinnati area.
Thanks, Matt. And our last question says, can you talk about how you break down the silos between the departments and how you maintain that? And I think that's a great question, and I'd be really interested to hear what each of you think about that. So I'm going to throw that to Rob first.
Well, I'll just, I guess, repeat myself a little bit, and that is mainly, I would say, communication and communication between departments, and also like operational literacy, if I may. So like being aware of how, not only what the programs look like and what is maybe the requirements for getting into that program, but how do they operate? And also, and this is something we had to learn pretty early on, which was, we would have let's say we met somebody while doing outreach, and that person tested positive, and we would just go ahead and, all right, great, this person's right here, easy enough. We'll do the medical case management intake right here, right now, and then, they'll meet their assigned caseworker, whether that's Jenna or Marcel or somebody on the medical case management team. Which seemed great, and it was great in some aspects. But what we were finding was that maybe those people, in the time that it took, days or weeks, to link that person with that medical case manager, the client might have developed quite a bit of trust with us as harm reduction service coordinators. And then it would be like, oh, here, and it didn't matter how much we were kind of preparing people like, hey, we're not going to be working with you forever. It's going to be this medical case manager. That would still be kind of a shock to some people's systems, where they would continue to call us first. We'd have to redirect. And the other thing is that Jenna and Marcel, thankfully, were what's the word? They were comfortable enough to say, hey, we would really prefer if we did the intake, or we started having these conversations before the intake, to be the ones to start to have those deeper conversations, those motivational interviewing, those more intensive motivational interviewing conversations. And then, write the case plan from there. So I think that, and then going beyond, of the people who have, for instance, moved through to be at Keracle House 3.0, that is, luckily enough, we'd have times that, myself, other harm reduction service coordinators were in a weekly meeting with Matt or Ann, and we could check in, say, hey, how's so-and-so doing? And they might be able to keep us updated in that way. So it's just keeping those lines of communications open and then understanding your colleagues' programs and how they work and how they prefer to work.
Thanks, Rob. Jenna, do you have anything to add to that?
I definitely agree with Rob. It's a lot of open communication. Even throughout the agency, Keracle really promotes and encourages us to come forward when we're having issues, either, interpersonally or with coworkers. So I think everyone feels pretty comfortable talking to each other and saying, hey, that didn't work out so well. Can we figure out a way it's going to work better? And understanding our role within the client's care. And then, like Rob mentioned, before COVID hit, we were trying to have monthly meetings with the HRSCs just to kind of touch base on the clients that we were sharing. And then, COVID hit and that kind of took a tailspin. So hopefully we are able to start doing that again, because it was helpful just to hear like, okay, Jamie's doing this with her. I could maybe start working on that instead, and kind of coming at it together. So definitely open communication and just having that trust in your coworkers.
Okay, thank you. And it sounds like you were kind of referring to, we have what I would kind of consider to be a team atmosphere. We're kind of all on the same team. There's no like, I'm on the prevention team and you're on the housing team.
Yeah, definitely. Especially when we're at the office. I feel comfortable going into anyone's office and being like, I need to vent, even if it's just about like something that happened with a client or, sometimes you just need that space where you can scream and then move on with your day.
Yes, you do. Sometimes need that. Matt, do you have anything to share? I think it'd be interesting to hear from you because like Jenna said, a lot of us are we're not in the office now, but normally we're in the office. And so that creates a lot of team building, but you're kind of off-site. And so I wonder how you see this from your perspective.
I do very much think Rob and Jenna covered the majority of it. I guess, again, to reiterate, one thing that Jenna said is the team's approach of Caracole, I think is very fundamental in terms of making sure that we're able to all work together. And that, I've heard other fellow employees that maybe have come from different agencies, they have mentioned that is really something that they have to adapt to at Keracle because it's not something that they're used to quite as much in previous positions, and that being the team approach that we take, the team meetings that we have, even being off-site pre-COVID, I was at the main office for a meeting with other individuals from other departments at least twice a week, sometimes 3 times. And that is really fundamental in the mixing of people from different departments and understanding how we all work together. And it could be, for those out there that are outside of our agency, we have maybe what we call a mixed group supervision. And a prime example would be that all of the clients that are in our housing programs are assigned to a dedicated team of case managers that handle and do medical case management for all the housing clients. So instead of those being interspersed throughout the entire agency, it can be amongst, I believe, 4 or 5 case managers. So then they can meet with the housing team and we have that team approach there where we get to meet and work together. And I think that that's very, very unique. That on top of, whole agency supervisions and monthly staff meetings, and just everybody feels very connected. And again, as Rob already said, it goes down fundamentally to understanding what each program does, how they function, what they're able to offer, and what their limitations are. I think Jenna touched on it. There's nobody at Keracle who I wouldn't feel comfortable calling up if needed and saying, hey, I need your help. I think sometimes maybe in other situations, you might have to pull teeth to get people to assist. And that just doesn't happen at Keracle. People are always willing to reach out and provide what's needed, which greatly contributes to the successful outcomes that we have.
Thanks for that, Matt. And I will just I have one thing to add to that question. I think everything that all the panelists said is completely accurate and true about how Keracle works. And Matt, you touched on this just a little bit, but I think one aspect that kind of keeps that going and keeps that open communication especially going is the way that we do supervision. So everybody gets individual supervision from their individual supervisor. There's department supervision. There's overall agency supervision that happens. And then there's continuous quality improvement meetings that happen. All of these things happen on a regular basis, probably monthly. Some people might have their individual supervision more than monthly, but that kind of stays on the front burner for Keracle, and I think that is something that helps to move that forward. So I guess we'll end on that. We went over, almost a half hour. Thanks to those who were able to stick with us and continue to hear about this conversation. And I hope that you all enjoyed it and learned some interesting ways that we're working together to serve our clients. Again, I'm just going to plug the session tomorrow at noon. It's Correctional HIV Prevention of Innovative Programs with John Coco and Abby Abrams from Step Up, Indiana. They're doing some really innovative work with people living with HIV who are incarcerated. So we look forward to that tomorrow. Please fill out the survey. Thank you to our panelists. This was great. Very engaging. And Matt, thanks for taking the time out on a vacation day to be here.
Hey, I'm just happy to participate from good old Jacobsburg, Ohio. Just the middle of nowhere.
All right. Bye, everybody. Have a great day.
Take care.
Bye. Thank you.
Thank you.